As I mentioned in the beginning, we will be taking questions after each speaker, not after the whole panel. So after each speaker, there will be a period for questions. Our first speaker is Shawna Mercer from the CDC. She'll be talking on interpreting the science, translating systematic reviews into guidelines. Mercer.
All right, it's a pleasure to speak with you all today and to have the opportunity to talk with you. And I'd just like to begin by acknowledging my co-authors here and giving the disclaimer that we must. I have been asked to talk to you about how the task force, the Community Preventive Services Task Force, actually takes systematic reviews and is able to put them together into recommendations. So in order to do that, I want to make sure that everybody's on the same page as to what the community guide is and who the task force are, so I'll start there. Then I will talk about the component parts that the task force considers when doing recommendations and how it pulls it all together. And then lastly, I've been asked to talk very briefly just about what we decide upon when we determine whether we're going to update our systematic reviews. So let's start with what the community guide is so we're all on the same page. Well, the community guide consists of two things. The first thing is state of the science systematic reviews that analyze all of the available evidence on the effectiveness of population-based interventions in a number of areas in communities and systems. And each of these systematic reviews also that are found to be effective, the reviews involve an assessment of the economics, the cost effectiveness, cost benefit. And the last thing that these reviews do is highlight critical gaps in the evidence. Well, the second thing that the community guide is taking these systematic reviews and coming up with evidence-based recommendations. These recommendations are developed by the Community Preventive Services Task Force. And what is this task force? Well, the Community Preventive Services Task Force is a non-federal, independent, rotating panel of members who are experts internationally in public health research, practice, and policy. There's a broad nomination process. The members are appointed by the CDC director, and they don't get any payment at all for their work. And CDC is mandated congressionally to provide support for the task force, and I direct the staff that supports the task force. And as a note, Nico Pronk, who is here today, is one of the members of the task force, and he certainly can help during the question time if there's anything he'd like to say. These are the topics that the task force has looked at so far across public health. And in each of these areas, what the task force looks at is the effectiveness of 4 different types of interventions. Interventions that look at are informational and educational interventions, the effectiveness of behavioral and social interventions, the effectiveness of environmental and policy interventions, and finally, the effectiveness of health system interventions in achieving the intended outcomes. So now let's talk about the component parts that this task force uses in coming up with its recommendations. How do we do the reviews? Well, the important question everybody thinks about is, does it work? Well, in public health, the world is so messy that generally it doesn't matter if it works if you don't know for whom, how well, under what conditions, how does it influence health disparities? What are costs, as I've identified earlier? Does it provide value? And what are the important considerations for implementation across all of the different settings? And because we are supposed to provide information of use for decision makers, tentative or partial answers are preferable to no answers. This is a general summary of how the task force puts its information together. First, it looks at a body of evidence. How many studies, what's the quality of the studies, what kind of study designs were used. And then, was there a demonstration of effectiveness, looking at 2 components. The first is consistency of effect. Were most studies in the right direction? And then secondly, sufficient magnitude of effect. And here we're not just looking at statistical significance, but was the effect meaningful? The task force has 3 options for recommendation. First, it can recommend for an intervention, or it can recommend against an intervention on the basis of strong evidence or sufficient evidence. Or it can say that at the present time, there's insufficient evidence to recommend for or against the intervention. The most important thing that we do when we start a review is that we come up with a coordination team that is involved in all parts of the review, in all decision-making and examination. So we include community guide staff, but we also include subject matter experts from research practice and policy settings, task force 1 or 2 members, and also members of the liaison organizations that sit with the task force. And they are involved in all levels of deliberation to make sure that we're staying true to the important questions to the field. There are 4 things involved in conceptualizing the review. The first is to come up with an intervention definition, then research questions, an analytic framework, and to determine applicability to different settings and systems. And as I've identified, the team is in constant involvement here in trying to make sure that we put the review together in a way that will be useful to the field. So in terms of intervention definitions, what we have for community guide reviews is a combination of a definition and a description of the intervention. And this is because things vary so much from setting to setting in public health. So we come up with words that are commonly used in the field, and we have 2 components to the definition. The first is the must-haves. This intervention must include this. Then we also have this intervention may include this because of that variability. And importantly, the intervention definition evolves over the course of the review because we can think we go in seeing what it will look like in the field, and that's not at all what we find when we look at the evidence. The second thing we do is come up with research questions. Those have been addressed very well today already. So our primary question is, does it work? The secondary questions are for whom, how, what are the limitations? The next thing that we do is to come up with an analytic framework that shows all of the potential ways that the intervention can lead to the intended outcomes, along with any potential effect modifiers, potential harms, and additional benefits of the intervention. This is the analytic framework from our obesity reviews, assessing the effectiveness of behavioral interventions that aim to reduce recreational sedentary screen time. And the red squares here on the right-hand side show the outcomes that can be considered as the basis of a task force recommendation. So the next thing that we do is go to abstracting study quality, something that there was a question about earlier today. We are interested in the utility of each underlying study for answering our particular research questions, so that a study might be well done, but it might not be rated as high quality in our study because there might be confounding factors that are beyond the researcher's control, or the researcher might have been attempting to answer a different question than we are. So when we look at the quality of study execution, we consider not just internal validity, but also limitations to external validity. And there are 9 possible limitations that a study can get across 6 domains. So we have a framework, and people look at each study against this framework. And the first thing they do is look for limitations in the way that the study was described. There are a whole series of questions asked. I've just identified one here. They can get a maximum of 1 limitation there. Then we move on to looking at any limitations in sampling, any limitations in measurement, any limitations in the way the data was analyzed, the way that the results were interpreted, and then any other things that the team thinks are very important due to the specifics of that review. So at the end of this, a study can be given 0 or 1 limitations and identified as good quality, 2 to 4 limitations, moderate quality, and anything with 5 or greater limitations, that's limited quality, and the study is excluded from further consideration. The other thing that we look at is the suitability of study design, and there are 3 different categories. We identify greatest suitability studies, and I've identified the designs here, study designs that are moderate in suitability, and the least suitable study designs. One of the biggest challenges that we face, I think you also face quite substantially with the dietary guidelines, and that is the fact that different researchers assess effectiveness with totally different outcomes. So researchers sometimes might agree on what are the important intended outcomes. For example, we want to increase food and vegetable intake, but there may be considerable variability in how they're actually measured across the studies. Some might look at servings per day, and others might look at odds ratios, and there's no way of putting them together. Also, the outcomes of interest may sometimes be combined and not be able to be disentangled. So some people put 100% fruit juice and sugar-sweetened beverages together. On the other hand, there might be a lack of consensus among researchers on what's the favorable direction for dietary outcomes. So for example, do we want to increase fruit juice intake, 100% fruit juice intake, or do we want to decrease it? So how do we deal with these multiple outcomes? Well, the community guide first starts by identifying the full range of measures of outcome, the team and consultants. And the second thing that it does is it attempts to lump sufficiently related outcomes together. And then when we cannot do a quantitative summary, which is often the case in the public health, there's too much heterogeneity for meta-analyses often, when we look at direction and magnitude of effects. There are, however, remaining very great implications in terms of loss and power, leading to often an insufficient evidence finding, and our greatest encouragement to researchers is to think about common measures. So this is a typical plot that is a typical community guide display of intervention effectiveness, where meta-analysis is not possible due to this wide heterogeneity I talked to you about. So the plot is from our behavioral screen time review, and the recommendation outcome is the amount of commercial TV viewing. The x-axis shows the amount of interest, and the y-axis is the list of studies the outcome of interest is across the bottom. And the y-axis is the list of studies in the review that reported the outcome. Each study is listed along with its length of follow-up and the number of hours of the day of commercial TV viewing at baseline. The blue arrow indicates, now this is the blue area in the middle that says favors intervention. This arrow indicates whether the data points to the left of 0 favor the intervention, or whether data points to the right of 0 favor the intervention. In this plot, data points to the left of 0 favor the intervention, indicating that there was a reduction in commercial TV viewing. We typically report the median and interquartile interval, or IQI, which is the interval between the first and third quartiles. We provide an IQI when there are 5 or more studies. The shaded area there indicates the IQI. For the high-intensity interventions, there was a median reduction in commercial TV viewing of 0.78 hours per day, shown by the dotted line, with an IQI of minus 3.4 to 0.61 hours per day. When there are less than 5 studies with data on a particular outcome, we report the range. This is the case for the low-intensity interventions on the bottom here, where the median reduction in TV viewing is 0.26 hours per day. This is another plot that shows the impact of behavioral screen time interventions on fruit and vegetable consumption. This time, the blue arrow indicates that points to the right of 0 favor the intervention, indicating an increase in consumption of fruit and vegetables. For the high-intensity studies, there was a median increase in fruit and vegetable intake of 0.16 servings per day for youth in the high-intensity studies, and a median of 0.50 servings for youth in the low-intensity with much wider confidence, or IQIs. Some studies cannot be plotted because they are just too different in terms of outcomes or other factors. From them, we abstract enough information to help the task force in its decision-making. This slide shows symbols that review teams commonly use when studies cannot be plotted. The double plus indicates the study results were in the favorable direction and statistically significant, for example. So here is a typical table for studies that could not be plotted because they reported different measures of energy intake. The columns provide important information about each of the studies, and the far right-hand column provides the symbol for an overall qualitative read of the table by the review coordination team and then by the task force. Here is another example showing fruit and vegetable intake data that could not be plotted given the various outcome measures and results, for example, differences in proportions and grams per day. Note that this is not vote counting, but providing the task force with an overall impression of whether the studies had effects that were in the favorable direction or statistically significant. This slide shows a less common format of how we present results in tabular format. Both direction and significance are represented by the colors and symbols in each box. This table was produced for our recent review of the effectiveness of built environment interventions in increasing physical activity. There was huge heterogeneity in how physical activity was measured in these reviews, as is shown across the columns. The table shows mostly positive findings, but does highlight the variability within and across studies and the outcomes for which there were more positive findings. So now we move on to the fact that we looked at overall effectiveness, and now we deal with the challenge of addressing the needs of decision makers for not just the internal validity of studies, but most decision makers want to know, are the findings generalizable to all of the settings for which I'm responsible, or are the findings applicable to my specific population? So what do we do here? Well, the community guide, at the start of each review, the review team identifies the applicability factors that are relevant for that review and comes up with a priori hypotheses. During the review, we collect data, and in the concluding phase of the review, we determine whether we can confirm or reject those a priori hypotheses. We routinely consider three components, things that differ in setting, population characteristics, and intervention characteristics such as do things differ by dose or duration. We always consider U.S. versus non-U.S. settings, race, ethnicity, and socioeconomic status. And all of the teams, as I've identified, then look at is there evidence or hunches that certain things do need to be considered in addition to the normal things we look at. The teams look at a number of sources of information. First, they look at the empirical evidence, what's available in the studies, in the review. Then they look at the broader literature. They also look at expert opinion, both the subject matter expertise on the coordination team, consultants, and others. And then they also look at theory. Is there a reason to consider that something would be important, even if we don't have evidence? And then they put this information together in multiple tables. What you see here in the left-hand column is a number of the factors that were considered for this behavioral interventions that I told you about before. Then how this factor is related to intervention in effectiveness, what the team thinks, and then on the right-hand side, points that they thought were important to be considered. At the end, they take that table and update it with what they actually found. So how do they put all of this together? Well, what's most important for the task force is, of course, is the intervention effective and was it consistent and meaningful? And then they also consider applicability, other effects like harms, additional benefits, considerations for implementation, and highlight evidence gaps. So I showed you this slide at the beginning, which identifies the things we look at, the body of evidence, consistency, and magnitude of effect. So let me talk a little bit about that meaningful effect that I talked about before. Well, the task force looks for effectiveness in achieving changes that are meaningful in a public health or population-based context. That might be very different than clinical effectiveness. And usually this requires some judgment based on the evidence that's available, which is often limited. So the evidence for meaningfulness may differ across topics and the available evidence. And what things that are considered are the type of intervention, what kinds of study designs and comparisons were available, the evaluated outcome and where it is on the pathway further to the end of morbidity mortality is important, and the strength of the measurement, whether it's self-reported or otherwise. The task force judgment may also be informed by effect sizes that are considered clinically meaningful, especially in health systems interventions. And the coordination team and task force also assesses information from the broader literature, what was found in previous intervention reviews in the same topic, and then their own dialogue, both the coordination team as it develops the review and then the task force at the meeting. All of this is put together into what we call our translation table. And as you can see across the top, these are the main components that we talked about. And each review is given a rating of quality of execution, what were the study designs like, how many studies, et cetera. What's highlighted in gray is what the task force found for the behavioral interventions that aim to reduce recreational sedentary screen time. So the summary of information on effectiveness is put forward in this format, where first we identified the body of evidence, how large it was, and then the impact on various recommendation outcomes. So across the 4 recommendation outcomes that are here, in general, the task force or the team first thought that the magnitude of effect was meaningful, either at the substantial level or the modest level, and that the findings were consistent across the bodies of evidence. Then they also looked at impact of disparities, and they found greater effectiveness in lower SES and lower education. The coordination team comes forward with a proposal to the task force. The task force deliberates that with with all of this, looks at the translation table, and comes up with its rating, and it agreed with the team here that it was strong evidence of effectiveness. The task force then goes through applicability, harms, benefits, considerations for implementation, and identifies gaps in the evidence that need to be filled by research and evaluation. The task force also has options to downgrade or upgrade a body of evidence for whatever reason. It has never upgraded, but it has downgraded, and that may be because there are major harms that it's concerned about and there's not enough evidence, or that there are serious recurring flaws in the body of literature, and these would be reasons that the task force could downgrade. What's important to note just in finishing this section is that there is judgment involved in community guide processes. Our methods are systematic, transparent, and published, but judgments are needed at multiple stages. And what helps with that is the fact that we use these coordination teams, have public settings, liaisons, and others to help inform our judgments and reduce bias at all stages. Now, I just want to finish. I was asked quickly to talk about what we decide to do or how do we decide when to update our reviews. The next speaker is going to spend most of his presentation talking about this, so I'm only going to address it very briefly. The task force's work order fills a number of different things. Its work list needs to look at three basic categories. First, updating existing reviews. Second, doing new reviews, and that might be new reviews in totally new areas or new interventions within a review area. And then sometimes people will come to the task force and ask it to do something special, like work on H1N1. So these are the task force approved criteria that it uses to prioritize both its new reviews and its updates. The burden of the disease, preventability, whether there are important disparities, the ability of the task force to cover a reasonable portion of a topic, the balance across public health topics to make sure we don't have all in tobacco and nothing in obesity, for example, how much audience and stakeholder interest there is at the time, what's going on elsewhere in the nation and how can we best align and not duplicate, and the degree to which the task force work can make a difference. For each of these, we have highlighted specific measures and assessment sources, and for our reviews, the updates, we also look at the amount of evidence and what has come out recently. And will doing a new review likely cause a change, or are we just going to move from a recommended strong to a recommended strong, as an example? And I will stop there. Thank you.